My name is Kim. What's yours? Just kidding. I've been asked to do this talk about disparity and some fundamentals of culturally aware care. And I believe the reason that I was asked to do it is because of our experience on the West Side taking care of refugees and immigrants. And I'll talk in a little while about a lady we actually saw here yesterday at this clinic that I saw with one of the residents who is an undocumented person seeking asylum and had suffered from female genital cutting. So this was, I think, a great experience for the resident because we had to look at the circumstances that brought her here to Buffalo, which are interesting in themselves. But these patients are really a rich resource for residency teaching and that we can provide really good care to. So what I'm going to do in the 45 to 50 minutes we have, I'm going to go over a physician's practical guide to culturally competent care, the basics of that. And for those of you who have to take your boards at some point, this does qualify for a Part 4 component of the boards, which is actually very nice for residents and attendings now. Then I'm going to talk a little bit about some of the disparities that we see, evidence-based literature. And then we're going to move on and talk about exactly what awareness and cultural competency implies in your everyday practice with patients and with each other. The class standards are very important, and I have handouts of those to give you. We're going to have a video today looking at the mandated class standards, and I'll explain all this as we go along. And I think you'll enjoy the video, and then we'll wrap it up. Are there any questions before we forge ahead? All right. So, you all know about Sir William Osler, who started his life in Canada. He's the father of modern medicine and teaching. And he said, it is more important to know what sort of a patient has a disease than what sort of disease a patient has. And I love this picture because this is the great man himself and doing a home visit on a patient. And I think one of the things as we move on in our primary care home models and our community care, it's a bi-directional direction with our community. So we see patients in our medical homes, but we also have outreach through community health workers, diabetic educators, because where a patient comes from and what forms their culture and their personal story is really what impacts their care and their health. So I love this picture of the great man himself seeing a patient at home. A physician's practical guide to culturally competent care. This is the website, Think Cultural Health. Truly, all of you who need to take your boards, residents, I think now have to take, do the maintenance of certification. This qualifies for a Part 4 component. I know that because I did it as a Part 4 component a while ago. It was really nice that I was able to do that because I actually had taken it before, so we went really fast. But it is a fantastic guide to culturally competent care for physicians and anybody else who takes it. It's not only for physicians, it's about practice-based care, takes place in the primary care office, and it is absolutely fantastic. Some of the things in your handout that this course covers, they talk about the rationale for cultural competence, they talk about why we need it, and what the evidence-based is for it. And there's a question, and I'm going to pose this to you all. I want you to think about that as we go through this. To what extent do you believe that you personally exhibit cultural competency in your practice? And this is not only for people who are practicing the clinical art of medicine, but people in offices, in the front office, anybody who relates to people in the medical arena. Do you feel that you are personally cultural competent to a very great extent, to a great extent, a moderate extent, minimal, or little or no? So just think about that in your daily life and practice. And hopefully as we go through things and you study on your own, you can continue to ponder that. But it's a wonderful site. And I do recommend it even if you don't have to take your boards. It would really behoove you to look at that. As you all know, the U.S. population is increasingly diverse. And this next slide, which shows a map of U.S. demography from the U.S. Census data, shows where we're going to be in 2050. Look at the increase in Hispanic, Latino, African American, Black, and Asian Pacific Islander. URM stands for underrepresented minority. And as you can see, we're going from about 30% currently. It's going to be up to 50% and beyond as the demography of the United States changes. This has a lot to do with immigration, not only refugees, but people who immigrate from other countries. And this is a reality, and to my way of thinking, it's fantastic. I mean, this increased diversity is going to do nothing but bring a wealth of richness for training and for clinical care. So it's happening, and you know, this will bring into play things like using interpretation, structured training for residents and medical students. I mean, this is really important stuff. I like this map because it really sort of shows where we're going. The next 3 slides are going to show you some evidence about healthcare disparities. In a way, I'm preaching to the converted, to a lot of you, because we take care of these patients every day. But this is all evidence-based. This particular slide was based on research done through AHRQ, the Agency for Healthcare Quality. Look at this, 30% of Hispanic and 20% of Black Americans still lack a usual source of healthcare compared to whites. As we'll see in the next slide, this doesn't always have to do with only insurance. The length of time between an abnormal mammogram and follow-up, twice as long for Asian American, Black, and Hispanic women than for white women. Preschool kids hospitalized for asthma, only 7% and 2% respectively of Black and Latino kids are prescribed routine follow-up meds compared to almost a quarter of white children to get that follow-up care. End-stage renal disease, Dr. Fox knows this well, almost 3 times higher among African American patients than it is among whites. And diabetes-related mortality is much higher in African Americans, Hispanic Americans, and Native or American Indians than it is in whites. Funnily enough, Asians and Pacific Islanders have the lowest mortality rate from diabetes type 2. And I don't know exactly why that is. Again, this is from the AHRQ fact sheet. And this shows that 31% of persons with a disability, and they looked at folks who had challenges in sight, in hearing, mobility difficulties, they reported in this one study fair or poor health compared to only 6% of the general population. Adults with significant disabilities had a 400% increase in an elevated risk of developing diabetes type 2. 3 times more likely in one study to commit suicide when compared to their peers without disabilities. And this data I know well. Adults with severe and serious mental illness die a quarter of a century earlier when compared to the general population. And this has to do with a multitude of factors, including poor access to care, poor treatment by providers, difficulty organizing care, poverty, a whole host of things. But this is the evidence-based. So we know this, and nationally, a lot of organizations have gotten together and over the last decade have published a wealth of materials that bring this into sharp focus for those of us that practice clinical medicine. The key book was Unequal Treatment through the Institute of Medicine. That really set the stage for looking at this data and really looking at how we're providing care to underrepresented minorities in America. The Department of Health and Human Services has a lot of literature. All of these are websites that you can access that have a wealth of things. The Office of Minority Health and Health Disparities has been renamed. It used to be OMH, Office of Minority Health, but because of the disparity problem in our in the states, it's now added on this health disparities description. Institute of Medicine, and the AAMC is doing great work for medical students in medical schools across the country. They have student groups, they have materials online that are just fantastic for medical schools to use for teaching. And at our medical school, there's a huge push now, and they have an Office of Cultural Inclusion and Diversity, headed by an associate dean now. I'm on one of those committees, and we're doing really interesting things, which I'll talk a little bit about towards the end, about teaching medical students and increasing the diversity of our faculty, our admissions committee, as well as our student body. So this, particularly when we look at UB moving downtown into the arena of where a lot of these underrepresented minorities live, this is going to be a wonderful match. So UB is really, I think, moving forward with a lot of policy changes that make a huge difference. So what is cultural competency? I mean, I think all of you are probably really alert to this. But in your handout, there is a description of it in the fast fact column. It's on the first page. And they define what sort of cultural competency is. It really refers to cultural and linguistic competence as a set of congruent behaviors, attitudes, that is exhibited by a group, like a medical office, or an individual who is dealing with folks from different cultures. Culture really is sort of this integrated pattern of behavior. One of the huge caveats in looking at health disparity and culturally aware care is generalization. That's a bad thing. You know, we can't say, oh, you know, people from Burma, they all speak Burmese, and they all do this, and they all are Buddhists, etc. Well, nothing could be further from the truth. For instance, in Burma, there are probably 6 religions that they practice, over 20 different dialects. They do not all speak Burmese. So the generalization of a culture, whether it be Burmese, African American, Latino, is dangerous. And most teaching and experience with these populations goes against generalization and really individualizing patient-centered care, which we're all used to in our medical homes, and listening to the patient's story so we know who that patient is and how they self-identify. And then competence implies the capacity to function effectively. Competence is the reason I used culturally aware as a term. Competence sort of to me means, I can do it, I know. You know, you're this and I know how to deal with you. Well, nobody is fully competent on any level, I don't think. Certainly not with different populations. And it's a process, it's a dynamic journey working toward learning what you can about different people. So generalization is out and patient-centeredness is in. So when we're thinking about disparity, these are the things that add and make disparities happen. A person's self-identity, they may identify in one way and we may put a label on them. You know, when we're talking about communication in medical care and health care, we really have to work with that person to see who they think they are, and then we learn from them, get rid of the power differential and really get on a level where you know your patient. Race and ethnicity, obviously, is a cause for disparity in America. Religion, age and gender, sexual orientation. I don't think we're very good in our offices about really asking about sexual orientation or referring services if somebody's in need of help. I know I took care of one of our refugees who was a gentleman but wanted to be a lady, and she was from Iran. One of the reasons she had emigrated was, of course, in Iran, if you're not, you know, what they feel is normal, you might be killed. So she was here looking for help. What she really wanted was the operation to become a woman, which we don't do here in Buffalo. But funnily enough, they have a wonderful center in Omaha, Nebraska. So she was referred there, and I don't know actually if she ended up going there, but you know, these are things that we really have to be, I think, more cognizant of in our care. Disability, you saw the slide about the increase, almost 400% in chronic disease for folks with disabilities. Obviously, socioeconomic status, poverty, and the determinants of health, which are all of these things, including the community where you live and work, safety of neighborhoods, access to healthy foods. All of these things determine how patients come to us, how we treat them, and how we can make their lives better. And that, again, goes back to community health workers going out into the community so we know where our patients come from so that when they come to us, we can deliver culturally relevant care. So the class standards, these are very important for culturally aware care. This came out of the Office of Minority Health based on the IOM report, and CLASS stands for Culturally and Linguistically Appropriate Services. They're in your handout, and what I want to point out about the CLASS standards, they are now nationwide. There's a caveat in one of these pages. They don't have the force of law, except in one circumstance, which I'll get to. But they are recommended for all organizations. Most hospitals now should be or are using the CLASS standards. And all of our offices should be using the class standards, certainly in the policy and procedure manual. And they're a series of 3 sets, or they're divided into 3 sets. There are 14 in all. The first set is the fundamentals of culturally competent care. And again, all of this is gone over in this wonderful Office of Minority Health online course. And then speaking of culturally competent care, and I'm going to focus on that today in the video because that is a mandate. That's mandated. So we'll talk about that. And then the last set of the class standards is structuring culturally competent care. So it talks about having a plan, how to implement that plan, how to share that with our patients, letting patients know and become aware of that we know that we want to be cognizant of these class standards and want to deliver the kind of care that makes them comfortable and allows us to do better care and for them to have better health outcomes. So the class standards are really the big thing that's come out of a lot of national planning. I wish they were a little more forceful so that there was a law if you didn't do them, you'd be, something would happen to you. But the 3, speaking of culturally competent care, we are going to talk more about because there is law and teeth behind that. Now, we are going to have a video. These are videos that were developed at Kaiser Permanente in California through their residency site. And we're going to see, I think you've seen this before, Red, have you?
I don't think we have.
Is it using interpreters? Okay. This is it's a primary care office, just like ours here. And it's scene 1 and scene 2. And scene 1 is a family, actually they speak Spanish, it's a Latino family, with a family physician and a MOA, you know, a nurse. And then scene 2 is the same setting, the same family, but they're a little bit different. So we're going to see these, and I want you to think from the perspective of everybody in the video. They're not very long, one's like 6 minutes and one's 5. I want you to think about if you were the doctor. I want you to think about if you were the nurse. And I want you to think about if you were the patient and their family. In the family, there are three people in the family that are in the office with a physician. The important thing to know about using interpretation, I know I've talked to read about this before, is it is the law. Now, if you don't see a lot of people in your office, you know, like maybe over 30% that don't speak English, it's okay not to have something like a phone, but you have to provide interpretation at no cost to the patient. And that means not using somebody down the hall that speaks the language or taking somebody off the street or using the child. It doesn't mean that. That's not correct. That means you have to call the International Institute and get a trained interpreter to come and be with the patient. Unless the patient has someone with them who speaks English and that language well and feels comfortable with that person, that's okay. Unless it's a very, maybe a mental health problem or something that you as the provider feel it's very important to have a trained interpreter because you really want to get the full story. Or you're afraid that the friend might not interpret correctly for that patient. Then you have to get a trained interpreter and you say, you know, sorry, you can have your friend here, but we believe that we also have a trained interpreter because I want to make sure that I understand correctly what's happening to you. So that's how you set it up, and you know, a patient usually is fine with that.
Doctor, the family insists on staying in the room.
Mrs. Rodriguez?
Yes, her cousin and her mother-in-law. I told them that we provide interpreters here at the clinic, but she's still a little unsure. It's just as well I'm very busy.
It says here that last week she was put on a 1,500-calorie diet plan for her diabetes and asked to follow up in 6 weeks.
Well, I think there's a problem.
Hello, I'm Dr. Royce.
Dile lo de la dieta.
Ay, pero no ahorita, yo no me siento bien.
Te lo estoy diciendo, es la dieta. No sabía nada, cualquier persona se sentiría mal comiendo eso.
Who speaks English?
I do. I'm Paulina, Lourdes' cousin, and this is Leticia, her mother-in-law.
All right, I need to get over here. All right, what can I do for you today?
Lourdes has been feeling dizzy and jumpy today.
Okay.
No es nada. Ella no tiene nada, solo nervios. Esa dieta pone nerviosa a cualquiera.
We think she's just nervous.
All right, any blackouts?
Blackouts?
Yes, has she ever passed out, became unconscious when she was dizzy?
¿Te has dormido cuando te dan esos mareos?
No, nunca. Pero yo ahorita me siento muy mal. Yo siento que me voy a desmayar. Y además siento como que el alma se me sale del cuerpo. Y luego las manos, además dile que siento como hormigas en las manos y en los ojos, así como que me veo cosas enfrente de ellos. Ay, y yo tengo mucho miedo de caerme y de que me vaya a lastimar. Ay, yo tengo mucho miedo.
No, está bien, está bien. Está bien, está bien.
Mucho miedo.
Lourdes says no.
Is she sticking to her diet plan?
El doctor quiere saber si estás siguiendo la dieta.
Yo estoy tratando, pero es muy difícil comer así.
Esa comida, esa dieta no es buena. Y no me vas a decir que estás tan mala como no poder cocinar para tu familia.
No, pero...
José trabaja muy duro y tiene que comer bien.
Pero es que yo no me siento bien.
What's going on?
I don't think Lourdes is sticking to her diet, and Leticia doesn't like the diet.
Well, it's not for her, it's for Lourdes. Tell her that this diet plan has been scientifically proven to be beneficial to diabetics. Lourdes must stick to this diet plan if she wants to avoid complications that can develop from her diabetes.
¿Qué dice?
Complications such as kidney failure, loss of extremities, problems with her eyes, heart attacks, okay?
El doctor dice que tiene que seguir la dieta. Es muy importante. Si no lo hace, le va a dar un ataque al corazón o puede afectarle los ojos, le puede poner ciega o enfermarse de los riñones, le puede dar algo muy malo. Debe de seguir con la dieta.
Es que nosotros no estamos acostumbradas a comer esa clase de comida. Y yo no la voy a comprar. Lourdes necesita cocinar y comer buena comida. Enchiladas, tamales, tortillas, carne asada, salsa y fruta.
Is Lourdes eating those kind of foods, enchiladas and such?
Claro.
Those foods are not on her diet list.
I think she is anyhow. Jose, her husband, and her children, they like to eat traditional Mexican foods. And I think his mother has him kind of spoiled. I've been trying to stay away from that kind of food myself because of the high fat. I'm trying to lose some weight.
All right. Lourdes cannot eat the traditional Mexican foods.
¿Qué dice?
If she gets sick, it's going to be your fault.
¿Qué dice?
Si Lourdes se pone mal, es su culpa.
¿Qué?
All right, would you ask her to leave the room? I would like to speak to Lourdes without her in the room.
Quiere que espere afuera. Quiere hablar a solas con Lourdes.
Este diabetes es la voluntad de Dios y nosotras no podemos hacer nada.
Leticia says that the diabetes is God's will.
Well, it doesn't matter. Lourdes still needs to stick to the treatment plan.
A él no le importa Dios.
¿Qué?
Ella tiene que comer las comidas de la dieta.
Pues es la voluntad de Dios.
Now, I want you to tell Lourdes that she must stick to this treatment plan. This is very important, all right? Regardless of what her mother-in-law wants, you see, Lourdes has type 2 diabetes. This occurs when the body cells have become resistant to insulin. This reduces the amount of glucose that can be used by these cells at any one time. Lourdes must get her blood sugar under control and keep it there.
El doctor dice que tiene que seguir con el tratamiento. Es muy importante. Tu familia está equivocada. El doctor sabe lo que hace. La glucosa no es suficiente. Dice que estás comiendo mucha azúcar. Que no comas tanta azúcar.
Perdón, doctor. Yo ya sabía que se iba a enojar.
Tell her that her dizzy spells are the result of her not following her diet plan.
Dice que con solo comer algunas cosas en la lista, ya no te van a dar esos mareos.
¿Sabes qué? Dile que me dé una lista de la dieta en español, porque en mi diccionario que tengo en la casa no aparecen las palabras de la otra dieta.
No, estuvo bueno por ahora. Mejor no molestarle al doctor.
Everything okay?
Yeah.
All right. Go ahead and make a follow-up appointment in 6 weeks from now, all right? Okay, good.
So, I love this video. So let's think about it for a minute from the perspective of the patient. How did she feel?
Probably like nobody's listening to her for one thing.
Scared and upset.
Right.
Right.
Right. And what about the doctor? Let's talk about that doctor.
Lost.
Busy.
Busy.
Right. Did he do anything right? What did he do that was right? Well, he knocked on the door. Okay.
He asked for a report of symptoms in the patient's or family's own words.
He did. Did he introduce himself? I can't remember if he said
He
it.
did.
Did he? Okay, so he introduced himself. That was good.
He did listen. I mean, he
did.
He did. He didn't interrupt.
He didn't.
He did. Not once did he interrupt on the whole thing. That whole thing was going on. He didn't interrupt.
Did he sit down at all during the interview? No. Did he in any way try to work with who this patient was? Did he ask for her story?
Well, he didn't even visually. He didn't even make contact with the patient. He just talked to the family.
Right. What do you think of the interpreter? Very sweet lady, right? Worried about her weight, wants to go on a low-fat diet, doesn't want to eat the Mexican food. But you can see what happens when you use someone who's in the family, knows the culture, knows the story, had no clue how to interpret the words that the physician was using. And was
also stuck in the middle of the family conflict.
Stuck in the middle of the family, put in a position to, the husband's doing this, the children, so as you can see, and this is why I like this video, it really points out in sort of a funny way that this is an impossible situation. You're not listening to the patient, you're not getting what that patient needs, you're not really dealing with the family, and he was busy. And of course, did you see when he first went in, he looked at the thing and the nurse said, "I'm busy, I'm out of here, good luck." And he rolled his eyes like, oh my God, now I have to use an interpreter, it's going to be longer, I don't know this patient, just sort of, but I have to tell you, this is, I felt this way. I admit it.
Well, but he had attitude going in.
I
saw her last week. I gave her a diet. Why is she here?
What the heck
how
is
dare
wrong?
she come back?
Right. Think of the difference if a community health worker or a diabetic educator had gone out in between and worked with this family, then it would have been a different scenario. I'm not saying that using an interpreter is short, because it's not. And I have been very frustrated sometimes in the same situation, hopefully not like him. But there are a lot of ways that could have made this easier. So now, let's look at the same setting, but a slightly different approach.
Doctor, the family insists on staying in the room.
Mrs. Rodriguez?
Yes, her cousin and her mother-in-law. I told them that Kaiser provides interpreters here at the clinic, but they're still very unsure. It's just as well I'm very busy.
All right, but I still want you to interpret.
Okay.
Is it possible to see Mrs. Rodriguez alone?
It is, but you need to understand that when Mrs. Rodriguez brings her family in, it's a cultural thing. It's important for all of the family members to hear what you have to say. Oh, also, the mother-in-law needs to be included in any of the decision-making and convinced of any treatment plan, or it may not happen.
Thank you. It says here last week she was put on a 1,500 calorie diet plan for her diabetes and asked to follow up in 6 weeks.
Well, I think there's a problem.
She seemed to be fine with the treatment plan.
Oh, don't be so sure. You see, sometimes Latinos, they have a difficult time saying no. They feel they're going to be insulting the physician's expertise.
So, we need to make sure that they really agree with the treatment plan and are not just being polite.
Exactly.
All right. If Mrs. Rodriguez is having trouble following the treatment plan, we need to find out why and try to get her back on the plan.
Okay.
Also, go ahead and ask any questions that you feel are necessary.
Okay.
Great.
Más de 45 minutos ya. ¿Pero qué es eso? ¿Qué clase de citas son esas?
Hola. I'm Dr. Joyce.
Ella es la doctora Joyce.
Yo soy Lourdes Rodríguez.
Soy Leticia Rodríguez. Mucho
Paulina.
gusto.
You've already met Mrs. Martinez. She's going to help us with the interpretation.
Ustedes ya me conocen, soy la señora Martínez, voy a ser su intérprete.
Dile lo de la dieta.
Ay, no, ahorita no. Si yo me siento muy mal.
Te lo estoy diciendo. Es la dieta. No sabía nada. Cualquiera se siente mal comiendo esa comida.
I sense there is a problem here.
Siento que hay un problema aquí.
Sí.
All right. I'll sit down and then we'll see if we can help you with the problem.
Bueno, vamos a ver cómo podemos ayudarla.
Okay.
Now, what's going on today?
Ahora, ¿qué está pasando?
Es que yo me siento muy nerviosa y estoy como muy mareada.
Lourdes says that she feels jumpy in her body and dizzy.
Lourdes no tiene nada. Es solo nervios. Que cualquiera se pondría nerviosa con esa dieta.
Leticia said that there's not much going on with Lourdes, that she's having an attack of the nervios, and it's the diet that's making her nervous.
I understand your concern for your daughter-in-law, and I understand nervios.
Dice que entiende su preocupación por su nuera y también entiende la razón por sus nervios.
Many times people with diabetes feel weak or dizzy. They don't have enough energy.
Muchas veces la gente con diabetes se siente débil o mareada, no tienen mucha energía.
It could be that Lourdes is having some of these feelings now. Do you think that might be possible?
Puede ser que Lourdes está sintiendo estos síntomas ahorita. ¿Puede ser eso?
A lo mejor, no sé.
Maybe, I don't know.
Are you worried about your diabetes?
¿Está preocupada por su diabetes?
Correct me if I'm wrong, but I sense there's a problem with the diet plan that you got at your last visit.
Dígame si estoy equivocada, pero ¿hay algún problema con la dieta que le dieron en su última visita?
Sí.
Sí. Yo estuve todo el tiempo tratando de seguirla, pero es que es muy difícil comer esas comidas.
Lourdes says she has been trying very hard, but it is very difficult to eat those foods.
Esa dieta no es buena.
That diet is no good.
What do you mean by no good?
¿Qué quiere decir con eso?
Que no tiene sabor. Y además no es la clase de comida que nosotros estamos acostumbrados a comer.
Leticia says that the food has no taste and it's not the type of food her family is used to eating. ¿Qué tipo de comida come su familia?
Comemos comida buena, enchiladas, carne asada, tamales, tortillas, salsa y frutas.
Leticia said that her family eats good foods. Tamales, enchiladas, tortillas, frutas, salsa.
I see. Oh, this is in English. Would you like to have a diet sheet in Spanish?
Dice que la lista está en inglés. ¿Quisiera una lista en español?
Sí, gracias.
Can I say something?
Oh, yes, of course.
Lourdes, her husband Jose, and their children like to eat traditional Mexican foods. I think his mother has him a little spoiled. I myself have been trying to avoid those kinds of foods because they're so high in fat. I've been trying to lose some weight.
Well, thank you for that. I understand that most of these foods are not the kinds of foods that your family is used to eating.
Entiendo que muchas de estas comidas no son las comidas que su familia está acostumbrada a comer.
I also understand that your family needs to have good foods to keep them strong and healthy.
Y también entiendo que su familia necesita buena comida para mantenerse saludables y fuertes.
All right. I think I can help by making some changes to the diet plan. Also, I think your family can help yourselves by trying to understand Lourdes's diabetes and her dizzy spells.
Creo que puedo ayudarles cambiando la lista de la comida y también su familia necesita ayudar para entenderlos, para ayudar tratando de entender tu diabetes y por qué se marea.
Yo comprendo que este diabetes es la voluntad de Dios.
Leticia says that Lourdes's diabetes is the will of God.
I understand. Isn't it also God's will that He helps those who help themselves?
¿Que no también es la voluntad de Dios que Dios ayuda a los que se ayudan a sí mismos?
Es la voluntad de Dios.
Yes, it is God's will.
Good. Now, some of the foods that you mentioned are very good.
Algunas de las comidas que mencionó son muy buenas.
The salsa, corn tortillas, and of course the fruit.
La salsa, las tortillas y la fruta.
I feel we just need to adjust the way some of the other foods are prepared so that Lourdes is able to eat them. In this way, Lourdes's diabetes can be better managed.
Siento que necesitamos preparar las comidas un poquito diferente y así el diabetes de Lourdes puede ser mejor controlado.
So, I'm going to get some help from our health educator or our dietitian here at Kaiser, who is more familiar with the kinds of foods you like to eat.
Voy a preguntar ayuda de nuestro educador de salud o de nuestro dietista de aquí de Kaiser para que les ayude a hacer la lista de comida que puede comer.
Also, I'd like to get some help from you, Mrs. Rodriguez, in working out a new plan.
Y también quisiera su ayuda, señora Rodríguez, para hacer una lista de dieta mejor.
Because I bet you are a very good cook and could make these changes easily.
Porque sé que debe de ser una buena cocinera y puede hacer estos cambios muy fácil.
A ver si un día le cocino para usted, doctora.
Leticia says that maybe she'll cook for you someday.
Oh, well, good. I feel if we work together to help Lourdes stay on her treatment plan, then she won't have to worry so much about these dizzy and jumpy feelings she's been having.
Siento que si trabajamos juntos podemos ayudar a Lourdes que coma mejor y así no se va a sentir tan mareada.
I'd like you to make an appointment for 1 month from now.
Quisiera que haga una cita de 30 días desde hoy.
And Mrs. Martinez will see that you get that diet sheet in Spanish.
Y yo me encargaré de que le den la lista en español.
Ay, gracias.
Qué bien,
Muchas gracias.
Muchas gracias, doctora.
Is there anything else that I could help you with today?
¿Hay algo más que les pueda ayudar?
Very good. Well, thank you for coming in.
Muchas gracias por venir.
Dile que gracias a ella.
Sí, al fin.
Adiós.
Adiós. Al fin encontramos
Ahorita
una
les traigo
doctora.
la lista.
Muy bien, gracias. Esta doctora sí que comprende.
Okay, so how did that go?
Much better.
Yeah, and what were the differences?
Well, you're not only a better interpreter, you're a much better clinician. The
doctor
great
spoke.
example of reflective listening.
Yes.
On the part, it was a great demonstration of reflective listening. Before she spoke, she said, "This is what I understood." You said, and made sure they were on the same
Right.
page before moving on to the next.
The other thing she did, which I love, and which we should all remember too, she sat down and immediately that power differential was gone. She was looking up at the patient. So the patient didn't feel like they were belittled in any way. And she even dealt with Paulina pretty well, who's trying to lose weight and doesn't like the fat food. So she certainly included her and said, thank you for saying that, without dismissing her in any way. I think the key point in that video, and in addition to using the correct interpreter, is when she looked at the patient and she said, I sense there's a problem here. And then the patient cried, and we've all been there, those of us who see patients. There's one moment where everything sort of stops and you really make that connection. So I like that video because it really points out how important it is to use the correct interpreter and what a difference it makes to the patient setting and to the health of the patient.
The interpreter is pretty crucial because in the first video there was a tremendous loss of information both ways.
Yes.
From doctor to patient, but also from patient to doc. And of course the nurse, being linguistically competent, was really able to interpret the medically relevant information. It was hard to imagine any family member interpreting that the doctor's really getting the richness or the symptom specificity that he or she needs to really respond appropriately, even with the best attitude.
Right.
You still need an accurate description of symptoms. And
you do, and also what this sets the stage for in our continuity of care realm is that if you don't use appropriate interpretation or appropriate interaction in your communication, that patient is not going to tell you things down the line. They're just not. They're not going to trust you, and they're going to realize that, you know, it's really not important to you. You don't really want to hear what I have to say or my family has to say. And so down the line it affects that health that will never be able to come out because they don't trust to speak to you. Let me just get this up. There we go. Okay, I want to end with, we're almost at the end. At UB now, University of Buffalo Medical School, we've been doing service learning projects for the last year and a half. It came to pass that students volunteer, medical students this is, and health professional students, they volunteer all over the community. The Lighthouse is here now. They've been volunteering there. They go to City Mission, Friends of the Night, refugee clinics, Jericho Road. They go to all of these places. But before a couple of years ago, they just went out, and sometimes they had preceptors and sometimes not, but there was no context given to these students. They were not able to discern why patients were coming to different places. They were so eager to practice their new craft, which is exactly right, but they were not really given the kind of training and background that they needed. So a group of us came together at the med school to really look at this and see how we could improve these experiences for students and how they could really learn about disparity in our community and how to approach this in a culturally relevant way. So this evolved into this service learning project. Now, any medical student who volunteers in the community must come to a reflective session at the med school led by a facilitator every time they do it. The reflective sessions are the last Wednesday of every month, and there's a group of facilitators that do this. And it might be 5 or 6 students who have been to different places in the community to volunteer. They must write a reflective paper, 1 page or more if they choose, and then we discuss it. And I wanted to discuss with you, I was there on Wednesday, and the students that I had, there were 5 of them. They had been to Lighthouse, City Mission, and Friends of the Night in this particular session. And these are the kinds of things that came up. One student said that she was reminded of the Tuskegee experiment, where syphilis was improperly treated and injected into Black Americans. She said that this actually came up with somebody that she was speaking to. You know, does everyone know what Tuskegee is? I had a patient years ago who I was starting on blood pressure medication, wasn't working, so the next time he came in, I said, well, you know, sometimes you have to experiment with medications. I used it in the sense of, you know, I mean, immediately every flag in the book went up for him, and he said, what do you mean experimenting on me? And Tuskegee came up there. These are real issues for patients in our community, so it's important that we know about them. I was very impressed that the student knew about this, and she was quite really eloquent about speaking about this person that she saw. The topic of racism came up, and we discussed this as a group. One of the students had heard another student say something that was completely racist in her mind. So we talked about that. You know, our students are from an era now where they are much used to learning and talking about this, and in some ways they're a little bit ahead of some of the attendings that they encountered. One student said to me that he was with a preceptor who was seeing a Burmese patient. They did not use appropriate interpretation and somehow tried to get through the visit. I said, what did you do? And he said, well, I'm a first year. I was with an attending. He said, I knew it was wrong. So, you know, this is the kind of thing that we're facing that we have to be alert to. They talked about interprofessional education. This is now happening at the med school. It's going to start, I think, in the January intersessions. This is combining nursing students, social work, medical, dental, because we're in teams now. Your primary care medical home is a team approach. The doctor can't do it all. Nobody can do it all. You need this team, and they need to learn this, and they want to. the students get it, and actually they can teach us a lot. They talked how important it is to know the patient's story. You really can't give good care or learn about your patient and their family unless you listen to their story. And every patient has a personal and particular story that makes their care totally different than anybody else. That's patient-centered care. They talked about how important housing is. The folks that were at City Mission know that people are there because they don't have homes. They don't have anywhere to go. So when they're discharged from Buffalo General or ECMC, and the social worker who's discharging them says, "Where are you going?" You know, you have to check the box, and they're like, "Well, street." So they go to the City Mission. And this really hit him. He saw patients who didn't have homes. How important it is to link them into the Buffalo Housing Consortium, or how important it is for us as a community to get better housing up for folks. Social work, the importance of connection with social work. How important jobs are. And in an economy where there aren't any jobs, how important it is to try to work with patients to find something that they can do. That this gives them pride, and it gives them a sense of belonging to their community. Access to care. I said a little while ago that insurance is important, but it's not the only variable. Many research studies have shown that you can have all the insurance that you need, but you still can't access care. People with serious mental health issues have Medicaid. They have full insurance, Medicare, disability, but they can't access care because offices don't want them. They can't make their appointments on time, so the office says, "Oh, third time, no show, you're out." Who needs medical care more than someone with serious mental illness? So the access is not only a point of insurance. I just spoke about the mental health. And then language, we talked about today, how important it is to use the correct language, to find out what a patient speaks and to use that appropriately in your offices. So I'll leave you with this. I think what we sometimes hear about is, well, why are they complaining? We treat her just like everybody else. You know, we did the same thing to him that we would do to anybody. Well, that's not really right. That's equal care, but that's not really what we should be thinking about. We should be thinking about equitable care, because that is patient-centered. That is, oh, okay, you're a little different, you need this, but maybe you need an interpreter, or maybe you need something else. And that is our responsibility to do that correctly for our patients so that it's patient-centered. And that is what is going to limit disparity. And there are some references for you.
It's interesting. You talked about the medical students getting it before us, which I think is definitely true. And
I think sometimes, unfortunately, it is.
Well, I wrote a paper about practice-based research networks, and I was the third author, but the lead author was a medical ethicist. And after doing this whole thing about patient-centered care and practice-based research networks, the medical ethicist thought about it and he said, "I think we're using the wrong terminology." He said to himself, he goes, "Wait a minute, let's say I injured my shoulder, and my next-door neighbor is an orthopedic nurse, and I have a friend who's a doctor, and I'm talking to them and I'm looking on the internet. Am I doing that as a patient or a person?" And he said, "I'm doing that as a person, so we really should be changing this to person-centered care."
A lot of people use that term, actually, person-centered.
Person-centered care. That a patient, we shouldn't be thinking them as patients. And right to your first point about the power distribution, of eliminating that power distribution. We're so trained in the power distribution we created.
And the hierarchy.
And the hierarchy.
Yeah.
And breaking that hierarchy, but thinking of it. So I said that to a group of residents when I was on rounds, told the same story. I said, "Oh yeah, it's not a hip in room 215.
Right.
It's a person who has a fractured hip. They got it like this."
Absolutely. Yeah. No, it's fascinating.
But if you talk to physicians my age or a little younger and you say that, very threatened.
Well, I've asked, the medical students that I work with, I've charged them with being ambassadors, so that when they go out and they're sort of afraid to talk to an attending, I say, that's okay, just either refer them to me, or just say, "Oh, gee, did you know that there's a phone system, or did you know you can hire an interpreter?" So they can help to educate the people who are not quite with the program yet.